Hello, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today I have a surgery lesson for you, that is blood transfusion tips. Please subscribe to our channel if you have not subscribed yet, and don't forget to give us a like at the end if you find the video useful. So let us not waste time anymore and start right now. Blood transfusion is the administration of whole blood or a blood product to a needy person. It has been widely used in the medical practice since the early 20th century to treat anemia and hemorrhage. The blood should be treated as a drug that must be prescribed with caution. The first successfully documented human blood transfusion was performed on a woman for postpartum hemorrhage by James Blundell in the year 1818. In 1901, the ABO system was discovered by Karl Landsteiner. In 1914, sodium citrate was first used as an anticoagulant. In 1932, the first blood bank was established in Leningrad Hospital. In 1939, the research system was identified as a major cause of transfusion reactions. In 1945, the Coombs test was discovered to identify incomplete antibodies. The blood is collected from previously screened donors. The volume of whole blood donated in one sitting should not exceed 13% of the total blood volume, and there should be no donation on more than 3 occasions in 1 year. Thus, the maximum blood a 50 kg donor should donate in one sitting is 450 ml. After donation, blood or blood product is tested for hepatitis B, hepatitis C, HIV-1, HIV-2 and syphilis. The donated blood is made leukocyte reduced or leukodepleted. It is 99.9% free from white blood cells as well as most of the platelets. As a precaution against febrile non-hemolytic transfusion reactions, alloimmunization to HLA antigens, and transmission of cytomegalovirus and Creutzfeldt-Jakob disease. Then ABO and rhesus blood groups are determined, as well as the presence of irregular red cell antibodies against the red cells of other minor blood group systems. The blood is usually transfused in 6 forms: whole blood, packed red cells, fresh frozen plasma, cryoprecipitate, platelet concentrate, and prothrombin complex concentrates. Technological advancements enabled the majority of clotting factors and albumin to become readily available as concentrates. They carry none of the inherent infection risks like other component therapies do. The stored whole blood is now rarely used because it progressively becomes acidotic due to elevated levels of lactate, potassium, and ammonia. But fresh whole blood has significant advantages over packed cells, as it is clotting factor rich and metabolically more active than the stored blood. Packed red cells are the product of choice for most clinical situations requiring transfusion. These are concentrated suspensions of red blood cells prepared by removing most of the plasma after centrifugation. Red cells are packed to a hematocrit of 50 to 70%. Its 1 unit of 330 ml contains hemoglobin, sodium, potassium, lactate, citrate, and water, and a pH of about 6.5. Packed red cells are stored in a SAGM solution, which is a saline adenine glucose mannitol solution. Their shelf life is 5 weeks at 2 to 6 degrees centigrade. Packed cells are stored in CPD, that is citrate phosphate dextrose solution, have a shelf life of 2 to 3 weeks. Fresh frozen plasma is rich in coagulation factors. Fresh frozen plasma is made from plasma separated from donor blood and frozen to minus 35 degrees centigrade to preserve it for up to 2 years. Third, that is warmed fresh frozen plasma has a storage life of 5 days. It is the first line treatment for coagulopathic hemorrhage. Fresh frozen plasma contains all coagulation factors except platelets. Fresh frozen plasma is the main source of vitamin K dependent factors, that is, vitamin D, vitamin E, vitamin K, and vitamin A, and it is the only source of factor 5. It carries similar infection risks as other blood components. Cryoprecipitate is made from fresh frozen plasma, which is frozen and repeatedly thawed to produce a concentrate of clotting factors. It is an insoluble white precipitate. Cryoprecipitate contains factor 1, that is fibrinogen, factor 8, von Willebrand factor, and factor 13. Cryoprecipitate is used primarily for fibrinogen replacement when fibrinogen levels fall below 100 mg per deciliter. Cryoprecipitate is also used as factor 8 replacement and in the manufacture of fibrin sealants and glues. It may be stored at minus 35 degrees centigrade with a 2-year shelf life and used in low fibrinogen states or factor 8 deficiency. Platelets are transfused as platelet concentrate. It contains about 25 million platelets per liter. Platelets are stored at 20 to 25 degrees centigrade with a shelf life of only 120 hours or 5 days. The volume of 1 unit of platelet concentrate is 50 to 70 ml. The indications for platelet transfusion are thrombocytopenia due to massive blood loss replacement with platelet poor products, thrombocytopenia due to inadequate production, and qualitative platelet disorders. Platelet preparations can transmit infectious diseases and can cause allergic reactions similar to those caused by red blood cell transfusion. In rare patients who develop antiplatelet antibodies through previous transfusions or who are refractory due to sensitization through prior pregnancies, HLA-matched platelet can be used. Increasing use of antiplatelet therapy such as aspirin or clopidogrel for cardiovascular risk reduction poses special problems. Aspirin therapy is rarely a problem, but control of hemorrhage in patients on other more potent platelet inhibitors can be extremely difficult. The latter may require continuous platelet infusion during active bleeding or major surgeries. Arginine vasopressin or AVP or its analog desmopressin or DDAVP are used in such patients, but results are limited or unsatisfactory. Prothrombin complex concentrates are highly purified clotting factor concentrates produced using recombinant DNA technology. These are available in 3 or 4 factor forms, either 3F or 4F. 3F contains factors 2, 9 and 10, whereas 4F contains factors 2, 7, 9 and 10. They are indicated for the emergency reversal of warfarin therapy to control bleeding either after trauma or during surgery. Autologous blood transfusion refers to the reinfusion of blood or blood components to the same individual from whom they were obtained. Pre-donated blood can be reinfused within 3 weeks. During surgery also, blood can be collected in a cell saver which can then be reinfused in the patient. This practice conserves resources and reduces the risk of virus or prion transmission. The supplies of blood and blood products are limited, and therefore their use must always be judicious, justifiable, and clinical need-based. Red blood transfusions are used to treat active bleeding, anemias, and to improve oxygen delivery to tissues. Indications of blood transfusion may be acute or chronic anemia, surgical hemorrhage, traumatic hemorrhage, non-surgical non-trauma hemorrhage, for example, peptic ulcer bleeding, sepsis with inadequate oxygen delivery, moderate to severe shock, acute ischemic coronary syndrome, chronic blood loss due to hepatic disorders or bleeding disorders, decreased blood production in malignancies, kidney diseases, or nutritional deficiencies. Transfusion trigger is defined as that value of hemoglobin below which RBC transfusion is indicated. The old dictum that a hemoglobin level of less than 10 gram per deciliter or a hematocrit value less than 30% indicates a need for preoperative red blood cell transfusion was challenged in 1988 in the National Institutes of Health Consensus Report. Now it is established that not only this is unnecessary, but is also associated with increased morbidity and mortality. Over the years, the trigger for transfusion has become more conservative and restrictive, such as hemoglobin level of 6 grams per deciliter is acceptable in patients who are not actively bleeding, not about to undergo major surgery, and are not symptomatic. Universal precautions during transfusion. Verify blood product for right patient and right prescription. Inform the patient about the procedure and complications of blood transfusion and obtain consent. The patient should be supervised for the first 15 minutes by a transfusion nurse and a paramedical staff. Check pre-transfusion vital signs, lung sounds, urine color and skin color. Prepare a white tubing with 0.9% NaCl or normal saline and the blood unit. The blood should be run slowly for the first 15 minutes, approximately at 2 ml per minute or 120 ml per hour. The transfusion rate can be increased after this period if the patient is stable and does not show any abnormal behavior or sign. Document and report vital signs after 15 minutes, then every hour, and finally at the end of the transfusion. During the whole transfusion, look for any abnormal signs. If a reaction is suspected, stop the transfusion immediately and report. Document everything. After the transfusion, flush white tubing with normal saline and dispose it in the bio-waste bin. Obtain and report post-transfusion vitals. Blood transfusion should start within 30 minutes of removing blood bag from refrigerator to prevent microbial contamination. Whole blood and packed red cell transfusion should complete within 4 hours. Platelet and fresh frozen plasma transfusion should complete within 20 minutes. The transfusion set should use a standard filter of 170 micron size. RBCs are stored at 1 to 6 degrees centigrade. The mean life of transfused RBCs is 35 days. Platelets are the only blood products that are stored at room temperature, that is 20 to 24 degrees centigrade. The lifespan of transfused RBCs is 4 to 5 days. 1 unit of platelet increases the platelet count by 5,000 to 10,000. The trigger for prophylactic platelet transfusion is 10,000 per microliter. For invasive procedures, 50,000 per microliter platelets is the usual target level. The platelet count should be 1 lakh per microliter before elective surgery.